So now the next topic we are going to start with is paralytic squint. Okay, in squint now we are going to start paralytic squint. So what is paralytic squint? So paralytic squint, a paralysis, and it could be due to any nerve disturbance or damage. Okay, so the paralytic squint occurs when there is an acquired defect of movement. It is acquired, okay, not congenital, it is acquired. And there is a movement in the eyeball. Okay, this acquired can be due to a damage, destruction, or trauma, injury. Okay, and this occurs by the disease. This occurs via the disease in the third, fourth, and the sixth cranial nerves. Okay, which are responsible for the ocular movement. So any damage, any trauma in these muscles, in these nerves, will lead to paralytic squint. So let us see different types of paralysis due to different types of cranial injuries. So third cranial nerve injury, or you can say it as a oculomotor nerve palsy. Okay, when this occurs, what happens? So first we will talk about the causes, that where the nucleus is present. So the nucleus is present in the midbrain at the level of superior colliculus. Okay, very important anatomical point of view. Now the third cranial nerves enters the lateral wall of the cavernous sinus. Okay, from the midbrain at the level of superior colliculus, it enters the lateral wall of cavernous sinus. Okay, then it passes through the superior orbital fissure. Okay, superior orbital fissure, where in annulus of Ziehen. Okay, so it goes over there, annulus of Ziehen. Now what are the nucleus associated over here? These nucleus we'll talk about, which are present in the midbrain at the level of superior colliculus. The nucleus has two parts, and these are main motor nucleus and the Adinger-Westphal nucleus. Okay, now first we'll discuss about the main motor nucleus. Now in the previous lecture we have discussed about the muscles which are present or which are responsible for the movement, okay, in the eye. Now what are the main motor nucleus which supplies the intraocular muscles? Okay, so these are the main motor nucleus which are supplying some intraocular muscles. Intraocular, remember, so some intraocular muscles, these are superior rectus, inferior oblique, and medial rectus. These are the four muscles which are supplied by the main motor nucleus. Simple. And these are further supplied contralaterally. Okay, now the most important thing over here, Adinger-Westphal nucleus, it supplies the sphincter pupillae muscle and the ciliary muscle. Okay, remember the Adinger-Westphal nucleus, it supplies the sphincter pupillae muscle and the ciliary muscle. Very important. Now the superior intraocular muscle, it also supplies the levator palpebrae superioris. Okay, so what all muscles are supplied by the superior intraocular muscle? Superior rectus, inferior rectus, internal oblique, okay, and the medial rectus. And what else? So lateral levator palpebrae superioris. And this supplies by the unpaired nuclei. Okay, these are supplied by the contralaterally, and these are supplied by the unpaired nuclei, means there would be two individual nucleuses for supplying these muscle. Okay, very easy and very important point over here. Now what are the clinical features which are related with the third cranial nerve palsy? Very important. These are ptosis, and ptosis is with the down and out eye. Okay, so there would be a bulging of the eye, or the eye will look out, bulged outward, and the eye will be downward displaced. Okay, so downward, and it would be forwardly displaced, and this will be with ptosis. Now, hypotrophia. So the next comes is the hypotrophia. The hypotrophia, there would be limitation of elevation. Let's see. So here you can see the limitation of elevation, and that is why it will drown. Then comes the another clinical feature, that is exotrophia. So the name itself tell us exo means the eye will bulged out. Okay, so there would be a bulging scene over here. Now mydriasis, and there would be no light reflexes. Okay, there would be no light reflexes with mydriasis. Now there would be loss of accommodation, and no near reflexes would be seen. Okay, loss of accommodation and no near reflexes seen. You can also see the very important thing, that is crossed diplopia. Okay, so you will see a crossed diplopia. Okay, and this is due to exotrophia. Simple. Now, what is the treatment associated with this third cranial nerve palsy? Okay, after the clinical features. So, we will observe the patient at least for 6 months. Okay, at least for 6 months, so that the third cranial nerve, which is injured or diseased, it could regenerate. Okay, now there is this observation process also, and there is a surgical method also. What is the surgical method? So basically in third cranial nerve palsy, the most common process which is used is this one, that is regeneration within the 6 months. But surgical means can also be used by the aberrant regeneration. Okay, so this includes two things, that are pseudo von graphic signs and pseudo ARP. It is nothing but pseudo accommodation reflex presence. Okay, now what is pseudo von graphic sign? So in pseudo von graphic sign, what is occurring? It occurs due to the fiber of the inferior rectus, and this misdirection to the LPS. Okay, so the inferior rectus is misdirected to LPS. Okay, on down gazing, both these inferior rectus and LPS contracts, and due to which it looks like a lid lag. Now why it is happening? Because the inferior rectus is depressing the eye. Okay, and the LPS is elevating the upper eyelid. Okay, due to which this seems like a lid appearance. In pseudo ARP, or accommodation reflex presence, there occurs is these fibers of the ciliary muscle are misdirected to sphincter pupillae, and the fibers of sphincter pupillae are completely damaged. So these two things is occurring in the fiber part. Now what this leads to? This leads to accommodation reflex present. There is accommodation reflex present, which is nothing but on a near vision accommodation is present. Okay, on near vision the accommodation is present, and the pupil will also constrict. Okay, and the pupillary light reflex is absent. What is this? This is nothing but there would be no light vision. Okay, no light reflexes would be seen over here. So simple. After the third cranial nerve palsy, now we are coming to the fourth cranial nerve palsy. Okay, and this fourth cranial nerve palsy is also known as trochlear nerve palsy or supranuclear gaze control. So fourth cranial nerve palsy or trochlear nerve palsy. Let's study about this. So we'll begin with the position of the nucleus of the third cranial nerve. It is situated in the midbrain at the level of inferior colliculus. Okay, remember here it is inferior colliculus, there it was superior colliculus. It leaves the midbrain on the dorsal surface after desiccation. Okay, then it enters the cavernous sinus, same on the lateral wall, but it passes through the superior orbital fissure outside the annulus of Ziehen. Okay, very important. And then it supplies, the important thing, it supplies the collateral superior oblique muscle. Okay, very important. Which muscle does it supplies? Collateral superior oblique muscle. Now coming to the clinical features of the fourth cranial nerve palsy. These are, what are the clinical features? These are cyclotorsion, hypertrophy. There is an increased hypertrophic adduction. Okay, remember increased hypertrophic adduction is over here. There is a increased hypertrophy on opposite gaze. Okay, and vertical diplopia is seen. Okay, there it was crossed diplopia, here it is vertical diplopia. Okay, the fifth comes is the head portion. For depression, there is a chin depression over here. Okay, intorsion, so head tilted towards the opposite side is seen. In depression, in adduction, the face turns towards the opposite side. So these three things are seen in the head portion. Okay, now coming to the treatment of the fourth cranial nerve palsy. So the treatment is surgical and it is according to the Knapp's classification. Very important. This is the most common procedure in the inferior oblique weakness. Okay, this procedure. Now, for diagnosis of any superior or inferior muscle palsy, what we are going to do? We will be following 3 steps in the Perk's test. Okay, Perk 3-step test. So in the first test, we are going to identify the hypertrophy I. Okay, in the second step, the hypertrophia increase in the direction of the clinical action of paralyzed muscle. Remember this. And either of the right gaze or the left gaze. This thing. Okay. Now the third step, in which hypertrophia decreases on tightening of head. Okay, it decreases on tightening of head in the same direction of cyclic action of paralytic muscles. Okay, so these were the 3 steps of the Park test. The last cranial nerve injury, that is the 6th cranial nerve injury. So we have studied the 3rd, 4th, and now it is the 6th cranial nerve injury. What are the causes? The nucleus is situated in the pons. Important point over here. Okay. Then on exit from the brainstem, it passes through the Dorlo canal. This is the another important point. Then it enters the cavernous sinus. It runs lateral to the lateral wall. Okay, it runs laterally through the wall and then passes through the superior orbital fissure inside the annulus of Ziehen. Another important points. So three important points: situated in the pons, passes through the Dorlo canal, and then it passes to the superior orbital fissure inside the annular of Zinn. Now, what muscles did it supply? So it supplies the ipsilateral lateral rectus muscle. Okay, so ipsilateral lateral rectus muscle is supplied by the sixth cranial nerve. Coming up to the clinical features. Clinical features of the sixth cranial nerve palsy includes isotrophia, uncrossed diplopia, very important point, and the head posture should be, the head should be turned towards same side. Okay, so the face should be turned toward the same side, and ipsilateral horizontal gaze palsy is seen. Important point another. So that completes with our nerve palsies. Now there are some causes of sixth cranial nerve palsy. What are these causes? So the first syndrome which comes is Fowley's syndrome. The Fowley syndrome is nothing but ipsilateral 5th, 6th, 7th and 8th cranial nerve palsy. It is with central Horner syndrome. These both things combine, and this is nothing but Fowley syndrome. Now the next comes is Millard-Gubler syndrome. Millard-Gubler syndrome. The ipsilateral palsy over here is 6th and 7th cranial nerve palsy. Okay, and here it is with the contralateral hemiplegia. Very important. Millard-Gubler syndrome. The next and the last comes is the Mobius syndrome, and there is bilateral cranial nerve palsy of 6th and 7th cranial nerve. In the next session of SQUINT, we are going to study the gaze palsy and the restrictive squint and the comitant squint or mics. Okay, these will be the topics.